Uh, I really appreciate the opportunity to be here and talk about something a little different. We're not talking about treating tumors at all, but more functional indications in the spine. But I've enjoyed every talk this morning. It's just been a wonderful day, so I'm really glad to be here. First, I just want to say that multidisciplinary approach to everything we do, I think, is the optimal way to manage spine problems in particular. And I'm very privileged to have an excellent multidisciplinary team at Sloan Kettering. What I'm going to talk about primarily is targeting the afferent sensory pathway with ablative radiation. And I'm going to really talk about two ways to do that, or two situations where that might be useful. One is in spasticity, and the other one is improving pain management. And really the idea for this comes from the paradigm that we're very familiar with, which is radiosurgery for trigeminal neuralgia. And this is just one. This is just one example, but with increasing doses, patients who suffer terribly from this condition can achieve very good levels of palliation. But we're talking about very high doses in a single fraction, 80 to 90 gray. But if you can do this, and we can do it safely, then the likelihood of a palliative benefit is actually very high and very meaningful. And so what I'm really going to talk about is applying that paradigm in the spine. And one of the, I found really interesting approaches for this in affecting the afferent pathway is interrupting the spasticity reflex arc. So I don't know if you ever had the experience when you're getting ready to go to sleep and you stretch your knee, your feet out, and all of a sudden you get a really terrible leg cramp. That does happen to me. I guess I'm getting a little older, or perhaps a lot older. Some of you who've known me for a number of years can say it's been a long time. But anyways, what happens if you get a hyper-exaggerated stretch reflex is you get this involuntary contraction of the muscles, and this increased involuntary muscle tone causes an imbalance, especially along the joints, where one muscle group has to relax and another one has to contract. And so in these exaggerated stretch reflexes, this arc can be interrupted in the afferent signal to reduce spasticity. So here's some examples of limb spasticity that can happen. Often it could be with spinal cord injury or brain trauma from strokes or other degenerative conditions, including multiple sclerosis. Often involving extremity flexors or lower extremity proximal extensors or upper extremity distal flexors, as these examples show. But this can be a very vexing problem. Our surgical colleagues have actually a very good solution for this, which is called a selective dorsal rhizotomy. So what they can do is go into the afferent pathways of electrodes, identify which parts of the sensory nerve root is causing the spasticity, and then go ahead and ablate it, either surgically disrupt the pathway. It can be done with chemical disruption or radiofrequency ablation. And now I just want to show you a very interesting experience with radiosurgery for these types of conditions. So this is from a preliminary series from Dr. Romanelli. And here's an example where what they do is they target the sensory root, the CSF space, between the dorsal root ganglion and the spinal cord. So as you know, there's a little pouch of CSF that goes out, and that's the area that they try to target between their dorsal root ganglion and the spinal cord. They give 60 gray for cervical roots, 35 to 45 gray in a single fraction for other spinal roots. And then they use a modified Ashworth scale to assess the amount of spasticity. And just to give you an idea what this scale is, 0 is like no spasticity, 4 is like completely fixed and rigid, and 3 would be a significant reduction in passive limb motion, and then the visual analog pain scale, because often spasticity is associated with significant pain. So here's their preliminary experience. It's a small number, but you can see that in every case, their patients had a significant reduction from almost like a frozen limb to going to, easily, MAS score of 2 means that it's easily moved with passive movement. So going from a fixed limb to having passive movement is actually a significant, I think, clinical benefit. And then they looked at the visual analog pain scores, and again, a reduction in the pain score, pretty significant improvement. This one patient was mute and couldn't report their pain, so they didn't record that. Another interesting experience is radiation of the celiac plexus for otherwise really difficult to manage retroperitoneal pain. So I found this to be a very interesting experience. And so in this case, they did 25 gray in a single fraction. Now, I know this isn't specifically nerve ablation because for these patients, there had to be tumor involving around the arteries. But the authors really think of it, I think, as a nerve ablation treatment. And so what they did is they targeted between T12 to L2. This is the typical field they gave. They used 25 gray in a single fraction, really taking it from the Stanford pancreas radiosurgery experience is where they got that dose. And then they would follow these patients. They treated 125 patients, 90 were available for analysis. And these patients actually had pretty significant and meaningful improvement in their pain and their opioid use, in their morphine equivalents. They did have some toxicity, and they even had 2 deaths that were not treatment related. But if you ever have a patient who has pain involving the celiac axis, these are very, very difficult clinical cases. They're very vexing. But this is actually, I think, a really interesting approach to radiosurgery involving the celiac plexus. The last thing I want to talk about is a little bit of our experience treating spinal back pain. It's the single back pain in general is the single leading cause of disability worldwide. And in the U.S., it's the second most common for a visit to a doctor, only outnumbered by upper respiratory infections. 80% of the population in the U.S. will experience back pain at some point in their lives, and Americans spend over $50 billion a year in back pain. So this is not just a medical condition. This is a societal problem. Is chronic back pain. There's lots of ways to deal with it. And so our thought was, again, building on the trigeminal experience, why not consider stereotactic radiosurgery? Because it's completely non-invasive, and we do have precedence for it. And so we started a pilot study, doing a dose escalation study, going up to 90 gray in a single fraction, targeting the afferent pathway in the spine. It's actually not that hard to find the dorsal root ganglion. So especially in the lumbar spine, it's actually quite easy. But you can even see it on regular CT imaging. So this is just, I just took this from one of our spine radiosurgery patients. We do a myelogram for most of our patients. So this is a CT myelogram simulation, maybe 2 millimeter slice thickness. There you can see the dorsal root ganglia. They're not actually that hard to find if you look for it. And there's actually a case report I found on I think this was really ahead of their time. They gave 80 gray in a single fraction for occipital neuralgia, and this patient had a very good outcome. So, I'm not claiming that it was someone had thought of this before we had and had good outcomes. What we found technically was that it's difficult to treat with these very small fields with a linear accelerator, not using cones to get, you need to have very small fields. But the cones that are typically used for functional radiosurgery in the cranium will cause collisions in the torso. And so we borrowed a technique from the University of Alabama called the virtual cone. And it's a very simple idea using MLCs, creating a small aperture, and then using arcs. And virtual cones actually give a dose profile very similar to gamma knife radiosurgery. And so this is the technique that we use. We use static arcs with a fixed aperture, no couch kicks. This is essentially 3D conformal radiation. There's no modulation required, and so the planning is actually very simple. And we can give doses 70, 80, 90 gray and keep the cord dose to within our radiosurgery tolerances, which are less than 14 gray to as a Dmax of the cord defined on a milligram. John Adler, early in their experience of CyberKnife, also had a report of treating using, he called it a rhizotomy for pain in the facet joint. A small series, which also showed 3 out of 5 patients having meaningful pain relief. And so in our study, we're currently in a dose escalation from 70, 80 to 90 gray. 3 patients per tier, very classic dose escalation, simple study design. We prescribed to the ISO center. And we also, which I think is kind of unique, is we're not also just measuring pain or morphine equivalents, because remember, these patients typically have chronic pain. They've had pain for years. And I'm actually learning a lot about how complicated that is, because it's more than just, there's a psychological or a psychiatric component to a lot of their pain. And so it's a little more complicated than I thought it was going to be. And I'm just going to give you an example of this, but one of the things we wanted to add to that, because we know it's complicated, is we do functional assessments. So we do peak flows, forced vital capacities, we do time, stand, and sit testing, as well as typical pain inventories. So we wanted to see if there's a difference between pain relief and function, because chronic pain is very complicated in many cases. So I'm just going to quickly tell you about one patient. This is our very first patient, 76-year-old patient with lung cancer. We're a cancer hospital, so all our patients have cancer. And this patient had previously had SBRT to a chest wall metastasis, and as you can see, is a pretty significant volume, and her tumor responded, and it's PET negative and has not been progressive, but had complained of 10 out of 10 pain for a couple of years. It found no relief. Part of our protocol is that we'll ask our interventional pain specialists to do a nerve block so that we know exactly which nerve roots to treat. And so to be eligible, they have to respond to a nerve block. And so this patient had transient pain relief from a block at T9, T10, and T11. So those are the ones we targeted. We gave 70 gray in a single fraction to each of those targets. Kept our dose constraints. In this case, the core dose at 70 gray, core dose was 7 gray. This patient reported significant pain relief within 3 weeks. She stopped her narcotics. She had improved functional measures, but about 2 or 3 months later, her pain actually started to come back. But what's interesting is that she started complaining of pain, but her functional status remains improved. And so despite having a lot of pain, now she can actually breathe better. Her sit-to-stand test is still very good. But again, this is why I think, treating patients who have chronic pain is very complicated. We are going to continue the dose escalation. So in summary, spine radiosurgery is undergoing an evolution. I'll call it an evolution. We heard a lot about metastatic disease. I'll talk a little later about treating primary tumors in the spine with radiosurgery. We heard a very nice talk about benign tumors treated with radiosurgery. But hey, we don't even need tumors anymore. We can treat the spine for other conditions besides just a tumor. And I think that the functional indications following the trigeminal neuralgia paradigm is going to be, has the potential to become a very potent force to help patients who otherwise have very few options and suffer from chronic pain that cannot be palliated. I gave you an example of celiac pain. We talked a little about spasticity, affecting the afferent pathway can benefit those patients, and also potentially treating chronic chest wall pain and spine pain. And I think it's important for us as a specialty to always be looking for new indications because we just can't keep doing the same thing. We need to be forward-looking, looking for new indications, and we have a very powerful tool in the form of spine radiosurgery that I think will be beneficial not just for malignant tumors or benign tumors, but also in patients who have no tumors but have functional have functional needs. And I think I'll stop there. Thank you for your attention.
Thank you very much, Dr. Yamada, for this great talk and sharing your experience in this specific area. Maybe I'm allowed to give a more comment as a question. I'm an orthopedic spine surgeon, so I deal a lot with pain patients and chronic pain. And I think, you mentioned it, but just to be aware of the complexity of pain, I think it is even more crucial to see these patients in an interdisciplinary setting before starting some sort of therapy, because otherwise, especially in chronic pain patients, if you attempt to do too much and repetitive interventional treatment attempts, you can even increase the chronic problem of this already chronic pain patients. So I think this is, you mentioned it, but just to make it very clear, I think this is really crucial in this specific patient clientele. So, but thank you very much. Are there any other questions?
Josh, that was a beautiful, elegant presentation. I have a question. The case that you showed of that patient, her tumor kind of swept around, presumably to that area. Do you have any sense of what those nerves initially got? And how did you choose your treatment dose? Because it looked like the field was potentially overlapping.
Yeah, the patient got 9 Gray × 3 SBRT to the chest wall.
And those nerves were infield or out of field?
Oh, they're all infield.
Infield.
Yeah.
Okay, and so your choice, would it have been different for targeting if they, would your dose have gone higher to start with in a slightly different indication?
Are you asking about ablating the nerve or treating the tumor?
Ablating the nerve.
Oh, yeah. Well, this is a phase 1 trial, and we don't really know what the best dose is, and so we're starting at 70 Gray. I have a feeling that until we get to the 90 Gray range, that's probably when we'll see our better outcomes. And so, we're not changing the dose because of prior radiation.
That was my question.
Yeah, we're just making sure that we meet our cord constraints. We're more concerned about meeting our cord constraints for reirradiation than we are about the nerve.
Josh, in that case, what was her paresthesia like, or was it already baseline? Because, you know, for some patients, and you're in thoracic, you're probably okay, but once you start getting into cervical thoracic or lumbar sacral, the paresthesias can be quite considerable. And
Yeah, we're actually not treating any of the plexuses. So we're avoiding the brachial plexus and the lumbosacral plexus. We're just treating, you know, like T2 through T12.
And did she get bad paresthesia after that, or did she already have it?
No.